Health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community.
Good morning, everybody. Good morning and welcome to our Khan Saturday Health Hour. It's an absolutely beautiful day outside, but I want to thank everyone for joining us today. We have such an interesting session ahead of us and I can't wait to get stuck in. Please do use the chat function. Tell us where you're from, wherever in the world that you're from. We've got a really detailed and interesting session today. You can ask questions in the chat box. We'll be monitoring that, and then the speaker that we have today will go through all your questions. My name is Emeka. I will be your host for this morning. I'm a pharmacist, but the guest speaker that we have today is Dr. Douglas Okor, and the session is going to be about brain cancer, essentially. Let's talk brain cancer, what do you need to know? So the speaker that is so kindly joining us, Dr. Douglas Okor, he's a consultant neurosurgeon. He's also a Nigerian sector reform advocate, an entrepreneur and a change agent, with a mantra that is known as the Nigerian patients are worth it, which I completely agree with. Western patients shouldn't always just get the best healthcare, should be extended to everyone worldwide. And Dr. Douglas Okor is really a driving force for this mantra and just providing the best healthcare to people in Nigeria and worldwide. Not only just being a doctor, he's also an entrepreneur and a co-founder with his wife of Ashanti Graham Health and Education Initiative Foundation, with a charity essentially with a vision of a 21st century healthcare for Nigeria. And I just think that is that's so great, and we're so blessed to have him joining us today all the way from Nigeria. And thanks to technology, we're able to hear what he has to say about brain cancer and all things neurosurgery. So without further ado, thank you all for joining. I'm going to hand it over to Dr. Douglas Okor now for a very interesting session. And please stay tuned for the whole session, because we actually have a video of a man talking about a lived experience with brain cancer. So I feel like that will be very interesting to watch. Yes. I'm going to stop talking now. Over to you, Douglas, Dr. Douglas, and yeah.
Thank you very, very much, Emeka, and thank you, Khan, for actually having me. First of all, I want to start by saying that Khan is doing an absolutely fantastic job when it comes to the health promotion advocacy and health promotion for ethnic minorities, especially Caribbean and African population in the United Kingdom. And of course, that extends outwards because of course, there are a significant number of people outside the UK that are actually going to be watching us talk about this very important medical condition that we're going to be talking about today. First of all, a quick question. Can we all see my slides? Is that a yes?
Yes, we can see them.
Okay, that's fine. So we're going to be talking about brain cancer today, what we need to know. So like Emeka said, I'm a consultant neurosurgeon here in Nigeria, in Abuja. I'm based in Abuja. I trained in the United Kingdom and moved back to Nigeria about 9 years ago. And so basically, I also work in the UK now and again, but I mainly work in Nigeria. Usually, I tell people that I live in UK, but I work in Nigeria. So brain cancer. So brain cancer basically can originate from the brain itself, what we call a primary brain cancer, or it can be something nasty that actually spreads from another part of the body. We either call that secondary brain cancer, or we call it metastasis. Okay, metastasis means when something moves from one part of the body, something nasty moves from one part of the body to the other part of the body. Basically, brain cancers are just abnormal cells, tissue that can be aggressive, nasty, sinister, happening in the brain. Like I said, there are mainly two types of brain cancers or brain tumors or brain lesions or brain growths, whatever we want to call them. There are those that actually arise from the brain itself, okay? So we call that primary brain cancers. And there are two main common types. They are the ones that we call the gliomas or the glial tumors. Okay, and these usually arise from the supporting tissues in the brain. The brain is usually composed of what we call neurons. Those are the nerve cells that actually conduct all the electricity from the brain to the rest of the body and from the rest of the body back to the brain. But those neurons or those nerve cells or those brain cells are also supported by other tissue, okay? And then this just gives you an idea. This is not an anatomy class where I'm trying to teach everybody about medical stuff already, but this is just to give you an idea. You have the glial tumors, and you also have the non-glial tumors as well. A very common example of the glial tumors is the one we call the glioblastoma multiforme, very aggressive. We call it GBM for short, glioblastoma multiforme, okay? And of course, when you look at the non-glial tumors, there's the one called the medulloblastomas, okay, which usually occurs at the back of the head, somewhere the hindbrain, and usually occurs more in children or young adults, okay? I won't go through yours, but this slide is just to show that, that you have primary brain tumors, and these are just the different types of glials and the non-glial tumors, okay? And this is just a picture. The one on your left is actually an example of the one I call the glioblastoma multiforme, the GBM. Very nasty tumor, very, very aggressive tumor, okay? If you look at that scan, you can almost appreciate the two eyes at the front, okay? You can almost appreciate the two eyes at the front and imprint of the nose. This is the right side of the patient's head, the left side of the patient on the back. So you can see this thing here, this nasty looking thing there. I'm sure everybody can see my arrow. That is the tumor or the brain cancer on the left side of the brain there, okay? And on the one on your right, of course, you can appreciate the eyes at the front there and so the nose. And this one, just in the middle there, this is the medulloblastoma. Like I said, usually occurs in young adults and children. Okay, so like I said, we just talked about the primary brain cancers, isn't it? So now we have the secondary brain cancers. And what did I say earlier on? I said these are nasty stuff, cancers, tumors, growths that spread from other parts of the body where there's actually a cancer in another part of the body and now spreads to the brain. There are four main parts of the body, or five main types of cancer, that actually spread to the brain. The most common one is lung cancer. I'm sure most of you all know about lung cancer or heard of lung cancer before, okay? So that's the most common source of a spread of a lump or some nasty growth to the brain, okay? Of course, breast cancer, okay? Breast cancer is actually very, very common, okay? Melanoma is a type of skin cancer, okay? A type of skin cancer, and that can also spread to the brain. There's a specific type of kidney cancer called renal cell carcinoma that also spreads to the brain. And of course, cancers that affect the gut, especially the lower part of the gut, going to the back passage, what we call the colon and the rectum, yes, and those cancers can also spread to the brain as well. Okay, so this is an MRI scan that just depicts those lesions or tumors that are spread from another part of the body to the brain. And we can almost count them easily. I'm sure it will be difficult to count them. That's 1, 2, 3, 4, 5. So this is like a multiple spread to the brain, okay? So it's not always multiple. Sometimes you can just have one lesion in one part of the brain, or 2 or 3, but this one is definitely multiple. Okay, so when we use the word brain cancer, cancer specifically talks about aggressive growth, aggressive tumors, okay, that really this will cause lots of damage, and these are the kind of tumors or cancers or nasty growths where if you do not deal with them, if you don't detect them early and stuff like that, an individual who actually develops this can actually run into big trouble. But there are other brain tumors, growths, lumps that are usually not cancers, okay, and I'll go through a couple of them, This is not exhaustive. Meningiomas. Meningiomas are actually quite common, okay? They arise from the meninges. The meninges is just the membrane that covers the brain and the spinal cord, okay? So this can actually arise. A significant number of meningiomas are actually not aggressive, okay? They are benign, okay? So the two ones are aggressive or a cancer and benign, okay? So meningiomas are not benign. Pituitary adenomas, okay? The pituitary gland is actually the gland. If I were to put my one finger here and another finger here, they meet in the center of my head. That's what the pituitary gland is. The pituitary gland is the master hormone gland of the body, controls all the key chemicals that make us alive, okay? Things like the cortisol or the steroids in our body, things like the thyroid hormone, stimulates the thyroid gland here to produce the thyroid hormones, okay? Produces prolactin, okay, where that women who actually give birth, that's what stimulates them to actually produce milk to breastfeed their babies and stuff like that. So you can actually have a tumor growing here, and it grows upwards. The nerve to the eye is just on top, so it grows upwards and pinches the nerve to the arm. People can actually go blind from that. Schwannomas. Schwannomas are actually tumors that arise from the sheet that covers the nerve cells, okay, or what we call the Schwann cells. An example is a vestibular schwannoma, which usually occurs on the nerve to your hearing and your balance, okay? And this is just an example of 3 of them. So on the top left there, you can see that very bright thing there on this MRI scan. That is a meningioma, okay, on the top right side of the patient's brain, okay? If you look at this one here, down on the left side, you can almost appreciate this patient's nose, the top lip there, the front of the head, the back, and that thing there, just in the middle there, is the pituitary adenoma, the pituitary tumor I talked about. And of course, when you look at this one, you can see the 2 eyes there. On the right side of the patient's head, you can see this tumor there, okay? And it's actually going into the nerve to the ear itself, and that's what we call a vestibular schwannoma. The vestibular nerve is the nerve that helps you control your balance, tells you, oh, I'm upside down, oh, I'm lying down, and stuff like that, okay? Okay, so what are the causes and risk factors? What causes brain cancers, brain tumors? People always ask these questions. Unfortunately, despite all the millions of pounds, dollars, and stuff that's been expended, okay, and invested in lots of cancer research and stuff, we still don't have a clear-cut understanding of how tumors, how they actually cost. But we can talk about some sort of risk factors. So there are what we call genetic mutations, where you have these rare genetic situations where you have, in a family, you can have people developing some kind of syndromes, okay, and they are predisposed to having brain tumors. There are lots of examples, but I'll just mention maybe like 3 or 4. So there's the neurofibromatosis, or what we call NF1. There's the neurofibromatosis 2 or type 2. There's the tuberous sclerosis complex, and then there's the Li-Fraumeni syndrome. So you can see that even the way I'm pronouncing them is not something that we should take to heart, basically. But all we just know is that there are these rare genetic syndromes that can occur in families, and sometimes they might predispose. And then you now talk about the issue of genetic testing and counseling in such families. Radiation exposure, especially to the head, okay? The radiation exposure can actually predispose to people actually developing tumors. Some tumors are more common in children, and others are more common in adults. Environmental factors, exposure to chemicals and stuff like that can predispose to generally cancers, and of course, cancer in the brain, but there's no clear-cut evidence regarding this, okay? And of course, some immune system disorders can actually predispose as well. But overall, the key takeaway from this is that, yes, while we talk about some risk factors that are not very clear-cut, it is difficult to actually determine, what exactly causes people to have brain tumors. And so they usually, and most probably a significant number of times, will actually occur spontaneously. So what are the symptoms that someone who is developing a brain cancer, a brain tumor, could possibly present with? Okay, so let me start with making it like a basic understanding of some things, okay? So you have the brain, okay? The brain sits in the skull, in the head, okay? And the brain has different parts of it. It has 2 sides, okay? You have 2 hemispheres of the brain, one on the left side and one on the right side, okay? And like I said, it sits within this rigid box, which I call the skull, okay? And different parts of the brain have different functions, okay? So first of all, remember, it's a rigid box, isn't it? So if you have a tumor growing within that rigid box, It's increasing the volume in that rigid box and will cause pressure in that rigid box. Okay. Also, a tumor growing within the brain will affect the function of that part of the brain that is actually growing in. Okay. A tumor will also irritate the brain as well. Okay. So 3 things I've said. It will cause pressure, it will affect the function of the brain wherever that tumor is growing, and it will irritate the brain. So we can now deduce some of the symptoms that a patient can present with. So headaches, persistent headaches. Okay, so a tumor is growing in the brain, causing lots of pressure in the head, that will result to headaches, isn't it? So when we have headaches that are out of the normal, not like the standard tension headaches we'll have where, oh, you're stressed, you're not sleeping well, you've not had a vacation, your work is really stressful, more around the temple area and stuff like that, you take some paracetamol and say it goes away. But when you're having headaches, it's persisting and maybe now associated with other kind of symptoms, get worried and go see your doctor. Okay, seizures, or like we say in lay terms, convulsions. Okay, remember what I said, that a cancer, a tumor can irritate the brain. Anything that irritates the brain at all can cause seizures. Okay, now we put here, oh, you can have visual problems, you can have hearing problems. Okay, now that just means that if you have a tumor that is affecting the pathway where where the function of it that subserves your pathway for you to actually see very well, you will have visual problems, isn't it? If you have like other, let me show you, like this scan here, you can see that the nerve for hearing is affected by the tumor. So in such a patient, you can have hearing problems. But another key thing, again, with respect to vision, is that when you have a cancer or tumor within this rigid box, it's called in the brain, and that tumor is causing lots of pressure and raised pressure within that box in the head itself, that pressure can be transmitted through the nerve to the eye, to the back of the eye, and that can damage the back of the eye, what we call papilledema, and that can also give you visual or sight problems as well. Of course, memory issues. Okay, especially with a tumor or a cancer that is on the left side of the brain for most people. Remember, most of us are right-handed, right? Most of us are right-handed. So if there's a crossing, so most people who are right-handed, the dominant hemisphere or the dominant part of their brain is on the left side. So that means your speech, your executive functioning, your cognition, most of the cognition will be on that left side. The right side is more for things like appreciating music, artistry, and stuff like that. Okay. So you can have memory problems, you can have cognitive problems, or that ability, that issue of reduced ability to actually function executively. Okay. Of course, when there's pressure in the brain and stuff, an individual who is developing a brain tumor or who has developed a cancer can actually have feeling sick, nausea, and vomiting as well. Now, remember what I said, that depending on where the tumor is, okay, it can affect the function. So if the tumor is somewhere around, or causing swelling around the brain, of the part of the brain that serves the function of moving your hand, for example, and moving a particular leg, you can have a patient presenting with issues that look like a stroke. Isn't it? Oh, I can't move one side of my body. Oh, I'm drooping on my face and stuff like that. Okay. The difference between this and a stroke is that usually strokes happen bang. This all of a sudden, suddenly, okay? But usually something like, okay, brain cancer and stuff will evolve and actually progress slowly. And of course, difficulty with speech or balance, okay? Again, like I said, whatever the tumor is, if the tumor is around somewhere where the speech area is, or something that will actually have to do with balance, then you have balance problems. Diagnosis, how do we now detect, oh, what is actually wrong with this person? Is this a brain cancer? What kind of brain cancer is this? Okay, so the first thing is go see a doctor. Okay, when you have any of these symptoms that I've talked about, a constellation of them and stuff like that, get worried. Okay, get worried and start going to see your GP, or of course, if it's something you're really worried about, please proceed to the accident and emergency. I know a significant number of people on this session now are in the UK. So guess what? Yes, even though the NHS is not the greatest in the world, it is significantly better than other places. So please, yeah, I know that the waiting times in A&E can be long as well, but please produce, if it's something where you're relatively stable, okay, your GP, your general practitioner, okay? But remember, part of what we are doing here is to impact you, so that when you even go to see your GP and they want to actually just shelve you off and stuff, they say, no, I know about brain cancer, I know that these symptoms I'm having, could possibly be that. Please, general practitioner, take this seriously, okay? And what I'm trying to say is that we're what we're doing is that we are impacting you guys with knowledge so you can actually run with that. Okay. So like I said, you go see a doctor, you go to a healthcare facility and they do a neurological exam, which means that they're just examining, some things like like how the different nerves that supply your face are functioning, how your hands are, so your speech, all that. So they do all those examinations. Now, because we are not voodoo priests, okay, and we don't throw cowries and stuff like that, we need to do special tests, okay, to actually find out what is happening. This person has come, he's confused, he's not moving one side of the arm, he's complaining of headaches and stuff like that. We start suspecting this might be something to do with the brain. So after the examination and stuff, we do tests. The key tests are imaging tests where you actually do brain scans, okay? MRI, CT scan. Now, remember that we talked about that we can have primary brain tumors. We can also have secondary brain tumors where they spread from elsewhere. So if we look at a scan, for example, a CT scan or MRI scan of the brain, and we say, hey, this, based on our experience, this might be something that's spread from somewhere else. Could it be that it's spread from lung cancer or from breast cancer, or whatever? So sometimes you will actually have symptoms of those other problems as well, or even a diagnosis of those other problems as well. But if you don't, you need to also do scans of the rest of the body. Okay, we call it a CT staging. Okay, so we call it a CT chest, abdomen, and pelvis to make sure and actually try and detect whether this is actually secondary brain tumor spread from somewhere else. Okay, now we talk about biopsy. The biopsy just means taking a bit of the tumor. Now, this just depends. Okay, it depends. You can see a patient with a brain tumor and their brain tumor is amenable to treatments, for example, like surgery, and then you actually do the surgery, and that's sort of a biopsy as well, because the biopsy just means taking tissue. When you do the surgery, you actually get tissue and send to the lab to actually find out exactly what you're dealing with. You can do spinal taps sometimes as well. Okay, for example, in children or in when you suspect metastasis. Okay, that can also help in terms of making a diagnosis or trying to detect exactly what's happening. And this is just images. The one on the left is an example of MRI scan. For those who are claustrophobic, it's a little bit scary. I've been in one myself. I don't know if anybody has been in one. Usually, these scans will take roughly somewhere between 40 minutes to 1 hour, 30 minutes. Okay, so sometimes some people even need to be sedated because, like I said, it's really a constrained space. But it's a really good machine for actually showing there's in terms of the clarity of what you're trying to actually find in the brain. And of course, the one on the lower right there is actually the CT scan. Much faster. In emergencies, what you actually need is actually the CT scan because it gives you a very strong idea what's happening at that particular point in time. So what are the treatment options? So these are the treatment options. I'm sure everybody can read, but usually there's a combination of these treatments. So surgery. In surgery, which is what I do, I'm a brain surgeon, okay? What you're determining to do is to, first of all, you're determining whether surgery will be helpful for this patient. Okay, that's our job. So in terms of treatment options, the specialty that has to do with brain cancer is called neuro-oncology or the neuro-oncology team. Okay, and you're actually having different specialists coming together in what we usually describe as the multidisciplinary team. Of course, you have the neurosurgeons there, you have the neurologists, you have the oncologists, you have the radiation oncologists. Of course, you might have the rehab people, the physiotherapists, speech and language therapists, and stuff like that. Okay. Now, for surgery, you have to take each case on its own merit. You look at a particular individual, everything surrounding this patient, and you now ask yourself, sitting in that multidisciplinary team, okay, and look at all the factors regarding that particular patient and say, hey, will surgery benefit this patient? Okay, now if you decide that surgery will benefit such a patient, then the best thing to do is to remove as much of this cancer or as much of this tumor as safely as possible. This is really critical. As safely as possible. It is better to remove some of the tumor and keep the patient alive than remove all the tumor and the patient is dead after the surgery. I hope you all understand that. Radiation therapy, okay, usually used post-surgery or when surgery isn't viable, when surgery is not, you can't actually do surgery in such a patient. And of course, chemotherapy using drugs to actually kill cancer patients. In a glioblastoma multiforme, the one I mentioned earlier, the GBM, okay, usually if a GBM is amenable to surgery, there's usually a combination of these three treatments in a GBM, okay? Surgery, if it's indicated, radiation, and chemotherapy, okay? Of course, there are these special targeted therapies, okay? There's immunotherapies where you're trying to actually, you understand, use the immune system itself of the person to actually fight the brain tumor. This is more, some of these medications are coming up, but it's more still within the research phase, okay? The most common types of treatment options are the first three: surgery, radiation, and chemotherapy. Okay, immunotherapy just coming on board, lots of research going into that. And then the last thing there is palliative care, unfortunately. Okay, there are patients that will see and things are really bad, and you can't do much for the patient, and then you just have to keep the person comfortable. Okay. Now, one of the things I always say, these are adage as brain surgeons. Okay, time is brain. So what we are trying to do, this advocacy about brain cancer, is to say, hey, with respect to all the symptoms that we've talked about, and what we're trying to empower everybody actually listening to me now, is that whenever you suspect anything based on the symptoms that you're having and stuff, time is brain. Okay, time, the early detection gives you the best possible outcome for anybody. Okay, so time is brain, extremely important. And of course, that's just a picture of myself and my team doing my thing. In Nigeria, yes, we struggle when it comes to looking at the key issues of capacity and capabilities. But touch wood, okay, since I've come back to Nigeria, even with the limitations that we have, we are making magic happen, even with respect to actually dealing with patients who have complex brain tumors and complex neurosurgical problems. So that's just a picture to actually show what we're doing. And I think this one was actually for a child. This was a child who actually had what I suspect was a medulloblastoma, if I remember well. Okay, so prognosis and survival. Do these patients, do they survive? That depends on different factors. Okay, so usually there's usually grading of these brain cancers, okay, from low grade to high grade. So for example, the glial tumors, the gliomas that I talked about earlier on, you can have from a grade 1 to grade 4, okay? The grade 4 is the glioblastoma multiforme I talked about. And of course, grade 1 is usually curable, okay? Grade 1, if you have a patient that has a grade 1 tumor, okay, and the patient presents on time, you take all the tumor, it is actually curable, okay? There's a tendency for grade 2, okay? If you actually sort the patient out, do surgery, possible chemotherapy, possibly radiotherapy, there's a possibility that they can actually survive for a really, really long time. But there's a tendency for the grade 2s to actually transform to grade 3 and finally transfer to grade 4 as well. But grade 4s are very nasty, very, very nasty, which is what I'm saying, like the high glioblastomas. Now, unfortunately, with the grade 4, sometimes even with early detection, okay, going ahead, doing surgery, if it's this sort of grade 4 is amenable to surgery, and going ahead to do, radiotherapy, chemotherapy, okay, the overall survival is still not great. That's how nasty this tumor is. Okay, so overall survival, sometimes you can get an average of 18 months, 2 years, despite everything that you've thrown in, okay? That's why it's really, really nasty. And of course, like I've said, the survival depends on different factors like the age. For example, if you have a patient who has breast cancer, for example, and has a spread of the tumor to the brain, and maybe it's just one tumor, one lump somewhere in the brain, okay, if you compare that with someone who has maybe like 6, 7, 8 lumps in the brain, there's a tendency that the person who has just one lump, and you can actually operate, deal with that one, or probably chemotherapy, radiotherapy, that person, the overall survival for that person will definitely be better than that person that has 10 lumps. So generally, this is the way we look at it. And of course, even a glioblastoma, as nasty as it is, there are tumor specifics in terms of the molecular and genetic make of that tumor. So you can have some GBMs where a patient will last longer or survive longer compared to other ones. I hope this makes sense. So living and surviving with brain cancer. Now, once the patient is diagnosed with brain cancer and possibly has gone through all these treatments that I've talked about, this will be what the person's life will be all about. Okay, so there'll be regular follow-ups and monitoring. Okay, for a patient who has had a brain tumor, has possibly had surgery, had all the other treatments, the adjuvant treatment like chemotherapy, radiotherapy, and stuff like that, probably maybe they have some weakness of their hands, have some problem with speech. Clearly, therapy and rehabilitation is going to be important. Physical therapy, physiotherapy, occupational therapy, speech and language therapy, depending on the patient. And of course, this is really important. Family is so important. Counseling, all that support. Okay, in a place like UK, it's really great. Most of the developed economy is really great. They have all the support groups and stuff like that. In a place like Nigeria, it's a struggle. But I give kudos to a particular group called the Brain and Spine Foundation Africa, being led by someone who's actually an engineer. Chika Okor, she's doing an absolutely fantastic job in Nigeria to try and push things and to try and create this sort of like a patient group to actually support people who have actually gone through things like this. And of course, like I said, lots of massive loads of input when it comes to resources going into research, trying to find new medicines, new things and stuff like that. And so now and again, a survivor and someone who has been treated for brain cancer who can actually be co-opted into some of these trials. Okay, prevention and early detection. Well, there's no guaranteed way to actually prevent brain cancer, okay? But clearly in these rare genetic syndromes and stuff, if you have a family where you have people within have rare genetic, of course, genetic counseling, testing and stuff for those groups, and it's really rare. It's not like, oh, there's a very large population, part of the population are having these rare genetic syndromes where they actually have a high risk. So if you actually have a family or someone within that sort of group, okay, then definitely trying to do this sort of genetic counseling and stuff can actually be a way of prevention. But generally, it's difficult to actually, there's no particular clear-cut strategy to actually say, oh, I want to prevent brain cancer. Okay. Another way might be, okay, if someone actually finds out, okay, going through the system, finds out that you have one of those 5 primary cancers in the lungs, the breast, the melanoma, the kidney cancer, or the colorectal cancer and stuff, actually managing those very well will be a way of preventing it from spreading to the brain as well. I hope that makes sense. And of course, early medical attention. That's what I say. It's an African thing, isn't it? The Caribbean, the African thing. Our presentation to the A&E, to our GP, is usually too slow compared to our other counterparts. Okay, compared to the Indians, the Caucasians, the Chinese and stuff like that. So that's why some of the advocacy is extremely important. Please, especially when you're in a place like the United Kingdom, for example, where you have access, at least some level of access. Okay, definitely better than most other parts of the world. Please, you understand, use it. Okay, once you actually have any symptoms that is suspicious, like once of those, please, early, yes, and going medical attention and all that. And like I said, for this genetic counseling for these specific families that have these rare genetic problems. So the key thing will be, what is the message, and some of the myths as well. So let me go through some of the myths. Brain cancer, okay, in the Caribbean African setting, if you look at most of the symptoms that will come with a brain cancer, a brain tumor and stuff, seizures, someone acting very funny, do you understand, having issues with behavior, cognitive problems and stuff, they all sound, from the African point of view, they sound spiritual, isn't it? Because the average Nigerian will say, oh, they've thrown arrow, oh, the enemies, the witches, they understand, and stuff like that. Okay, so I think what I'm trying to say is that we should play that down. No, brain tumors and brain cancer are very real. It has nothing to do with spiritual, nothing to do with they've thrown you arrow, they understand, stuff like that. No, brain cancer is real, the primary brain cancers and the secondary brain cancers. Okay, now the other myth is that, oh, brain cancers are fatal. Once you have a brain cancer or a brain tumor, so you're dead. Okay, now what I've said is that not all brain tumors are aggressive. Okay, so that's why actually engaging with the healthcare system and engaging in a timely fashion is extremely important. So from all the issues of looking at risk factors, looking at examining the patients and making a diagnosis and early detection and stuff like that can actually help in terms of overall survival. And for patients who can be cured, will be cured. Okay. There's the issue of cell phones. Use of cell phones, do they cause brain cancer? Yeah, that has been everywhere, but it's not been proven at all. Okay, there's no general fundamental, do you understand, type 1 evidence, you understand, that, oh, using phones actually causes brain cancer. Okay, another myth is that, oh, it's only the older age groups, only older people that have brain cancer. No, we have actually seen this is new, what do you call it, infants. An infant is a baby that's less than 1 year actually having brain cancer, actually dying from brain cancer. Okay, so it affects all spectrum of all ages. Okay, from the traditional setting, there's this thinking that, oh, only traditional medicine, okay, only herbal medicine can cure brain cancers. Okay, you do some voodoo, do some incantations and stuff like that. And, no, in fact, one of the, I'm not playing down on traditional medicine or herbal medicine, okay, but Amaka, you're a pharmacist, you know that, that even most of the drugs that we use come from herbs as well. But when it comes to going through the mill of doing clinical trials, of looking at safety, which is actually really important and stuff like that, before you even go to efficacy and stuff like that. So I'm sure there are herbal medicines that have constituents that actually will help with different illnesses, but that issue of actually making sure that they go through the standard clinical trials and they are safe for humans, and of course that they're effective, is actually really important. Okay. And there's also this myth that if you do an operation to remove a brain tumor, or you do a biopsy, it can make the brain tumor spread as well. No, that is not true. Okay. Surgery or biopsy is part of the treatment and part of the diagnosis of treating a brain tumor. Okay. And so basically, like I said, the message here is that whenever you have any symptoms, like I described earlier on, that you feel is suspicious, okay, it's out of the ordinary, headaches, having convulsions, okay, convulsions, very, very key, having headaches that are persisting, they are out of the ordinary, you're having seizures, having problems with the issue of cognitive problems, person is not as sharp as before, being confused, okay, developing issues with, you're not able to move one hand, you're drooping of the face and stuff like that, having problems with vision and stuff like that. That should be ringing the bell and reminding all of us that time is brain, and that whenever you detect anything, any sinister thing or almost sinister thing that is affecting the brain, that early detection will give you the best possible outcome. And again, for those of us living in the UK, please, you have the resources at your disposal. You have the facilities and have that wherewithal in terms of the platforms that can actually help you if you actually develop any of these problems. Please use them. I'll stop there for now. Like I always say, the Nigerian patients are worth it. Okay, clearly, all Caribbean and African patients are worth it. All patients all over the world are worth it. But this is just my own forte. That's one of the reasons why I actually came back to Nigeria, to actually push the reforms for healthcare in Nigeria. So that's why I say the Nigerian patients are worth it. So I'll leave the space. I'm sure, Emeka, we are about to play a very important video, and then after that, we'll have the questions and comments. Thank you very much.
Yes, thank you so much, Dr. Douglas Okor. That was absolutely brilliant. I was locked in. We've got plenty of questions in the chat. I've been making some notes. So informative and educational. We'll get into the questions, but just before that, we've got a short video from a man called Uncle Josh, who is going to talk through a lived experience with brain cancer. So I'm going to hand it over to the Khan team, who will play the video.
Dr. Okor, can you kindly stop sharing? I think that will help. Thank you so much.
Done.
What do you want people to learn out of your story? What lesson do you want them to learn? What's the word to the public? What's your word to people?
The thing is, when you find you have a problem, don't keep it to yourself. Go to your GP and talk about it.
Good afternoon, and I give you a warm welcome to the Lived Experience session of Health Hour. And I'm here with a very special guest. It's my pleasure to introduce someone with a very powerful story and very, very inspiring. Uncle Josh is here with me on the call, and he is a survivor and a lived experience of a brain tumor. I'm passing on to you, Uncle Josh. Thank you for joining today's Health Hour session.
Thank you for having me.
Yeah, so how did you come about when was it diagnosed, and how did you feel before you got diagnosed?
Yes, before I got the first disease I had before I saw about the brain tumor is that I had eyesight problems. I had the cataracts. The cataracts were removed, and I found that my vision was not improving. I was at the diplopia. That means seeing double vision.
Wow.
So I went back to the doctors that did the cataracts, and they said that they're going to take a scan. When they took a scan, that's when they found that I had a brain tumor. And whilst this was going on, I was finding that I was getting tired, feeling cold, having a deep voice.
Wow.
And also sometimes constipation and increasing weight. Because of that, I went to my GP and I told him I'm not feeling all right. He took my bloods. When they came back, he said, "Oh, you are not eating properly. You are not eating proteins." I said, "No, I eat a balanced diet all the time." So after that, they said, "Well, let's take a scan." When they took a scan, that's when I found that I had a pituitary tumor.
Wow.
Well, I can understand why I was having problem with vision, and increase in weight, feeling cold. And I found that I got tired very quickly. If I ran a few breathless, I got breathless very quickly. If I ran, about just 10 yards, I could hear my heart pounding. And I said, "What's going on? Is it old age?" I said, "No, I can't be feeling old like this." So after they found out I got a brain tumor, I was sent to Salford Royal Hospital where they operated on me. The brain tumor was very big.
Wow.
They use pinhole surgery. You know where they don't open your head, they just make the hole.
A pinhole surgery, pinhole, yeah.
They put a needle through my nose to the tumor. Because the pituitary is if you touch the palate of your mouth, the roof of your mouth, the pituitary is on the other side.
Oh my God.
Yeah, so they did that. They had to do it twice because it was difficult for them to remove it at once because it was still affecting my eyesight. I'd lost. I could only see like that. What was here? I couldn't see. So after they operated it twice, still they couldn't remove it all. So they said they were still doing pinhole surgery. And they said, "Can you open your head?" I said, no, that is enough. So after that, they sent me for deep radiotherapy to Christie's Hospital. So they did deep radiotherapy. That is to stop that tumor growing, the piece that was left behind to stop it growing.
Okay.
And then after that, my vision became very good.
Oh, great.
Yes, now I read every newspaper, everything. I no longer have a problem with vision.
Wow.
Yes.
Congratulations. You're one of those very few people that has survived the whole, and I can imagine the impact on your work, your lifestyle, and the tension in the family. Would he see? Would he lose consciousness? And just to ask, Uncle Josh, was there any period during this period, that time that maybe you were not mobile, you weren't able to speak, or you lost your memory?
No. I only one day I just found that my head was spinning. Okay. I was in bed and the head was spinning. I couldn't understand why. I went to the GP and he just gave me a tablet. That was prior to the surgery. But during the time I did this, I never I just slowed down. I found that, like I said, sometimes I found constipation was one of the biggest things. And I ended up buying 2 pairs of trousers, which were very, very big. I think if I show you my belt, what it was like, I'll show you my belt.
Wow.
Yeah. The holes, because I was using a much longer belt than I used to. Wow. Yes, but after the surgery, thank the Lord, everything worked. I now feel the person I am for my age. Yes.
So about how long was this from the time you got this diagnosed to the time you had the surgery, about how long was it?
Oh, the diagnosis was in 2011.
Okay.
And then 5 months later, they did the surgery.
Okay. I can imagine the tension in the whole family at that period. Oh my.
No. You see, the thing is, I accepted that sometimes things do happen when you think they should happen. Because if it happens to you, don't say, why me? Because everybody else doesn't want it.
Yeah.
I just took it in my stride and said, I'll wait to see what comes at the end.
Okay.
Yes. Yes.
And thank God you saw it to the end and you are a survivor. You are a strong person. And for you to really share your story today, we're incredibly proud of you. And, you know, it's hard to get people that will want to pass through that journey and wanting to share with other people to adjust their lifestyles. So what adjustments have you made in terms of since that time till now, in terms of your lifestyle, your diet, so exercises, what have you been doing?
Well, exercise, I do walk a lot. And also now, because the pituitary is the gland that controls the whole of your body, the whole of your body is controlled by the pituitary. So now there are parts of my body which are no longer functioning, like this gland here, the thyroid. So I have to take tablets for it. And also it was affecting my blood pressure. So I'm taking tablets for blood pressure. Because there's a hormone that should be controlling your blood pressure, but mine is no longer working. And also my kidneys are no longer doing as what they should be doing to produce a hormone. That a hormone that helps you digest food or control your stresses. So I'm taking that in tablet form.
Okay, yeah.
Yes, but
well, good to know that
are working well.
Okay, yeah, good to know that you're receiving the right medical care.
Yes,
and,
I am.
Yeah, so what would you like to what do you want people to learn out of your story? What lesson do you want them to learn? What's the word to the public? What's your word to people?
The thing is, when you find you have a problem, don't keep it to yourself. Go to your GP and talk about it. If you're not happy with your GP, ask him for second opinions.
Second opinion, yeah.
Yes, because if you don't ask for second opinion, you can't say one person is right all the time. It doesn't work like that. Yes, that's the other thing. And also, for me, I was lucky because I knew about I worked in hospitals, so it was easy for me to understand what was going in my body. But you know, when they teach you, you are not supposed to find out what is wrong with you. Let other people see it, not you yourself say, I think I've got this. No, ask people to look at you and find out what exactly is going on.
Yeah.
Yeah, because my voice was so deep. And I said, why? Why? Because this coldness and the bigness of the body, it makes this pituitary gland makes your body slow down. So even your voice box starts being like a bass guitar where should be a lead guitar.
Yeah, I can imagine. Yeah, thank you so much, Uncle Josh, for sharing a very inspiring story. And Dr. Okor has told us so much about brain tumor this morning. So thank you so much once again. Your openness and the courage you have put up this morning. Your openness, your courage to share your personal experience is something that will leave a lasting impact to our audience.
We all learn from each other. We all learn from each other.
Yes.
No person is an island.
Yes. And we're so grateful for sharing your voice and insights with us this morning. Thank you very much. So
You're
over
welcome.
to you.
Well, thank you so much, Uncle Josh, for that video and sharing your experience. I feel like it's so touching to see people who have undergone these hard experiences, these tough experiences, and made it through the other side, sharing their experiences to encourage others. And it's people like you, Dr. Okor, who make these things possible, who do these difficult operations and give people a chance again to live. So I really think that was great for sharing that story. Thank you, Uncle Josh. We're going to get into our questions now, and it has been such an engaging, interesting session. We've got a lot of questions. We've got 20 minutes, so I'm just going to try and get through these. But I'll start with the first question that someone in the chat has asked. I know you touched on this a bit in your myth busting session, but some people have asked about a couple more myths. First question: there are myths on brain cancers which we would like to clarify. One, that it can't be cured. Two, that it will always come back. 3, do they really have natural remedies to cure cancer like people claim, or is chemotherapy the only way? So are you able to touch on that a bit, Dr. Okor?
Yeah, the question, can it be cured? So it depends on what you're actually dealing with, okay? I've told you there are different types of cancers, okay? There are different types of brain tumors. I think somebody asked that question. What's the difference between a brain cancer and a brain tumor? Okay, now let me start with this first. A brain tumor is the umbrella, is the big umbrella. Okay, they can have brain cancers and others that are not brain cancers, but are actually lumps in the brain as well. So it just depends on exactly what you're dealing with. If you're dealing with a very low-grade glial tumor, for example, like what we call a pilocytic astrocytoma, you remove it, the patient is cured. Okay, if you're dealing with a grade 2, for example, okay, you remove the tumor, you do all the other treatments, and it's not just chemotherapy, okay? Like I said, the 3 standard treatments are surgery, radiotherapy, and chemotherapy, and you can mix these 3 together or use two of them or whatever, depending on the tumors. Also, for like a grade 2 of the glial tumors, you do surgery, you do all the others possibly, the patient most probably will survive for a long time. But like I said, there's a tendency for that to convert, and become more aggressive over time. Okay, most of them will convert over time. Okay, but you might find out that someone who has a grade 2 is surviving for 20 years, okay, but someone who has a grade 4, which is the very nasty one, is surviving for 2 years or less. Okay, so can a brain tumor be cured? Yes, depending on what type of brain tumor it actually is. What was the other question again? Oh, traditional remedies. Okay, so when you look at the standards of treatment of brain cancer or brain tumors, traditional remedies don't come into play at all. At all. Okay, if you look at all the research that's been done, all the policies and protocols out there for actually managing brain tumors, brain cancers, and stuff like that, you will not see anything about herbal remedies or natural whatever and stuff like that. But if a natural remedy, I'll state this very clearly, if a natural remedy or a herbal remedy is safe for a patient, for a patient, and the patient takes it and psychologically or whatever, the patient feels good with themselves, of course you can take it, but don't expect that is a treatment strategy for brain tumors.
Okay.
Okay. Can I just quickly go through other things just quickly? So in terms of other, I covered some myths. Let me cover others very quickly. Contagious. Oh, brain cancers can be contagious. Oh, don't go near that person. It will affect you as well. No, brain cancers are not contagious. Brain cancers are hereditary. Oh, my father has brain cancer, I will have brain cancer. And I've said that very clearly. No, it is only in very rare occasions that you have these rare genetic syndromes in some families. Okay, and for that, you're not doing genetic testing, counseling, and all that for those people in that family, and it is rare. Okay, nothing can be done for a patient that has brain cancer or brain tumor once it's diagnosed. Again, I've said it very clearly. There are different types of brain tumors and different types of brain cancers. Can you see why it's very, very important that someone actually goes to the hospital and let the experts do their thing and actually find out exactly what you're dealing with? For example, Uncle George had the pituitary tumor. If we all remember, when I was showing the images, I showed it with the pituitary tumor, the one that Dr. George actually had, the one that can grow and actually affect the eyes. Okay, a significant number of brain tumors like George had are benign. They are not cancers. They are not aggressive. A significant number of those. Okay, so there's a tendency that I can actually achieve cure in someone like the tendency of achieving cure someone like Uncle George is really, really high. Brain cancers have very obvious early signs. Though sometimes they can actually take some time. Okay, you can have the brain cancer growing and stuff like that, and you don't have even these symptoms that we talk about. That's why we must all be very, very sharp and alert. Very, very important. All brain tumors are cancerous. I've answered that question. Yeah. All of them are cancerous and aggressive. So you can go ahead.
That's right. And we'll move on to the next question. Are you able just to touch on what are the screening tools available for brain cancer, for detecting brain cancer?
Okay, so like I said, in terms of screening, in terms of prevention and stuff, we have nothing, unfortunately, for brain cancer specifically. Okay, nothing for brain cancer specifically. Okay, but of course, I've stated a very clear specific group, isn't it? A very rare group where you have just a genetic predisposition to some kind of cancers. Now, it's a genetic predisposition. It doesn't mean that everybody in that family or anybody in that family will have brain cancers. But those are the kind of people that you might say, oh yeah, whatever this person has in this family, and this can go in particular families for people in at least first degree relatives in this family, let us do genetic screening and counseling and all that for them, okay? And then go through all the meals of doing the genetic screenings. They're probably doing scans based on whatever symptoms the person has and stuff like that. So that's specific. But you remember that I said that there are secondary brain tumors, isn't it? They're secondary brain tumors. So for example, breast cancer spreads with the brain. Can you do screening for breast cancer? Yes, you can, okay? Colorectal cancer can spread to the brain. Can you do screening for colorectal cancer? Yes, you can, okay? That's the answer.
Do you feel like this leads into the next question? There's quite limited screening tools for brain cancer. Do you think that like leads into why some cancers are difficult to diagnose early? Why does it seem difficult to diagnose some?
So for example, this is a very good question. So let's compare the UK, for example, and Nigeria, where I am. Okay, in the UK, okay, you have the National Health Service, and your accessing of care is free of charge. You're not paying anything at the point of accessing care, isn't it? So anybody has a problem and stuff, as long as you can go, and that's what we're doing here. We want the African and Caribbean population in the UK, whenever they have any issues, to actually go to their general practitioner with their full chest. That's what we say it in Nigeria, your full chest. Do you understand? And because they have this information, they are really empowered. They can go to their GP and say, GP, I'm really suspicious based on the symptoms that I actually have, isn't it? And because you already have that, that means that in terms of early access, easy access and stuff like that, you can actually go there, and then the chance of detecting this early and getting the best possible outcome, getting the best survivor for anybody is relatively good in the UK, isn't it? In Nigeria, we don't have that. We do not have that, okay? Healthcare is very expensive. You have about 133 million plus multidimensionally poor people. Access is very difficult. Affordability is very difficult. So there's a tendency in this part of the world, in Nigeria, for people to present late and not have generally very good outcomes. So that's understandable. But please, for the Afro-Caribbean community in the UK, please, okay, you have these things at your disposal. Okay, so whenever you're suspicious based on everything that we've educated you today, please go to your GP and go with your full chest, okay, and be very confident to tell them, hey, I have read about these things and stuff like that. I'm very suspicious, and because of my suspicion and stuff like that, and because I know and I've been educated that early detection will give me the best possible outcome and stuff like that, please, GP, do something about it.
Yes. Okay, thanks for that, Dr. Okor. The next question, what is your opinion about the use of phones and AirPods with regards to increasing risk of brain tumors? And does accumulated stress, does that cause brain cancer as well?
So the one about using the phones, I've answered that very, very clearly. There is no clear-cut evidence regarding that, none whatsoever. Of course, research is still ongoing, okay? But there's no clear-cut evidence out there stating that clearly, oh, the use of phones will actually cause brain cancer, none whatsoever. Sorry, the second thing was about
the accumulated stress. Can that be a risk factor?
No link at all. None whatsoever.
Yeah.
Of course, stress and everything is bad for your health, isn't it? It's generally bad for your health. But in terms of stress or whatever being a risk factor that can predispose you to having brain cancers, no, and definitely no.
Okay, thank you for busting that myth. I've got another question, and I think it was when you were talking about the symptoms of a potential brain cancer. So I wanted to ask, how can we relate this to FND? I'm assuming that's functional neurological disorder, given that most of the symptoms expressed also intermarry with FND.
Yeah. So functional neurological disorder, to me, realistically, I don't deal with that. I'm a brain surgeon, so we do the operations. Yeah, it is the neurologists. They are more intelligent than us, so they are the ones that do like the high quality. They are very intelligent and stuff like that. So a functional neurological disorder, to me, is more going towards more of like a mental health functional problem. Okay, so in those kind of patients, you do a brain scan and stuff, you don't find anything at all, and they say, oh, it's some sort of disconnection of the wiring of the brain and stuff like that, and then you now find out that they're actually presenting with some of these symptoms that mimic the symptoms of a brain cancer as well. But clearly, what is the issue here? Whether it's a functional neurological disorder or it's going to be a brain cancer and stuff like that, you will never know until you actually go to that GP, until they actually examine you, investigate you, do the scans. Okay, now if they do a scan and you don't find any brain tumor, you don't find anything sinister, hooray! Okay, is it possibly a functional neurological disorder? Okay, possibly. But the key thing is that whenever you're having any of these symptoms, they must be assessed. You must be assessed and investigated because, like I said, time is brain.
Okay. Oh, okay. Thank you. Thank you so much for that. We've got the next question, which I suspect may have been asked by a healthcare professional. The question asks, will you say that there is an emergency with brain tumors, meaning that should someone worry if they miss this on first presentation, they're talking medico-legally?
Okay, so so generally with brain tumors, usually I will describe them in terms of how you actually deal with them as urgent to an emergency, depending on how the patient is presenting. Okay, so for example, an individual says, "Oh, we're having headaches for a really long time. Now and again, I'm having some memory issues and stuff like that. The headaches is really bad, maybe in the early hours of the morning, I vomit now and again and stuff like that." Okay, I think that's sort of urgent. Hey, let's find out what's happening. Oh, let's make sure it's not something sinister. Okay, that's sort of urgent. Now, a patient has a convulsion, becomes unconscious, okay, not moving one side of the body and stuff like that. One of the people's the darkness in the eye is blown, so that is an emergency. So whether it's going to be an relatively urgent or an emergency will depend on how the patient is presenting.
Okay. Depending on how the patient is presenting, yeah, I completely agree with that. This question is quite heavy question. Someone has asked, personally, as someone with metastatic breast cancer to the brain, can it ever be cured? They're stating number 7, and it's quite tiring. Is there any hope? I think you touched on these different kind of cancers that start, secondary ones that start and spread, the outcomes. Is it dependent on the individual and what stage they're at, or?
So clearly, yeah, you're absolutely right. So it just depends on what stage they're at as well. So in terms of the specific answer here was a cure, isn't it?
Yeah.
Can it be cured?
Yeah.
So in this kind of case where you actually have a cancer that spread from somewhere else to the brain, maybe one particular lump or maybe a couple of lumps and stuff, whatever treatments you're having, chemotherapy, some sort of radiation type therapy and stuff like that, what you're doing is that you're just managing things and trying to just like get the optimum for the patient. You cannot use the word cure in such a patient. You're just managing things and trying to get the best possible, and stop things from spreading and stuff like that. That's what you do. But curing, no, you can't cure stuff in such an individual.
We're moving on to the next question. Someone has asked, how does cancer spread from the lungs to the brain? They feel so far away. Is it in the blood? So this is more like a physiological biology question. Like, how does it?
So simple. It's usually mainly through the blood.
Through the blood.
Mainly through the blood. In fact, most of the spread from all the things we talked about, from the colorectal, from the kidneys, from the lungs, the breast, is usually through the bloodstream. We call it hematogenous spread.
Yeah. Okay.
Most of it. Almost all of it, but most of it.
Someone else has asked, can syringomyelia, I'm just making sure I've read that right.
Yeah, you're right. You pronounce it very, very well.
Yeah. Can that cause brain cancer? I'm not quite sure. So
syringomyelia is something totally different. That's something totally different.
Okay.
Okay, so syringomyelia is just talking about where you actually have some distortion in the way the brain fluid moves around the brain, down the spinal cord, because the brain produces fluid, okay? Yeah. And it moves around the brain to wet the brain, nourish the brain and stuff like that. So when there's a problem with the movement for any particular reason at all, okay, there can be a situation where the core of fluid within the spinal cord itself now starts expanding. We all have a very thin cylindrical core of fluid within our spinal cords, but because of the flow of the fluid outside it is distorted and stuff, the core of the fluid now starts getting much larger in terms of the diameter and stuff, and starts putting pressure on all the fibers, the wires going up and down, carrying information up and down, and then the patient can have a problem with that. So that's totally something different from a brain tumor. Could a brain tumor cause it? Yes, a brain tumor could cause it, not the single myelocard. So for example, if you had a brain tumor in the area where the head goes down the spine in the neck, for example, and the tumor is blocking the flow of fluid through that area, of brain fluid through that area, it can cause a situation where there's a distortion of the dynamics of the fluid flow and cause the coring and expansion of the core of fluid within the spinal cord itself, not the other way around.
Okay. Thanks for clarifying that. We've got someone that's asking, because I think you touched on a session about exposure to radiation can cause or help propagate cancer. Someone's asked.
So radiographers.
Yeah. Can a radiographer be exposed to the radiation at work? Like, how do you limit that exposure?
Yeah, absolutely. So usually what happens is that we have these lead jackets that we use to, even myself as well. In theater, for example, when I'm doing spine cases, we have our what we call our fluoroscopy machine that gives radiation and does X-rays when we're doing spine cases and stuff like that.
Okay.
So most healthcare providers who are actually provide service in such a way that they use this kind of machines that use radiation and stuff can be exposed. So how do you protect them? You use the lead jackets. Sometimes you actually have these sensors. Okay, you have these sensors that actually give an idea of how much exposure you're actually getting and stuff, and that usually helps us. So yes, you can be exposed, but the key thing is to actually protect yourself.
Okay. Okay, thank you for that. Someone has asked, they've apologized for it being a silly question, but there's no silly questions around here.
No, there's no silly question at all.
Someone has said, brain tumors, are they different from brain cancer?
Yeah, so I sort of explain that.
Yeah,
so the umbrella is brain tumors. So brain tumors, any lump, any sort of lesion, growth, whatever in the brain, we say it's a brain tumor, isn't it?
Yeah.
A significant number of them are brain cancers, where they're actually primary brain cancers arising from tissue in the brain itself, or secondary brain cancers spreading from somewhere else. And I told you the 5 common places where they will actually spread from. You can have other brain tumors that are not classically cancers as well. They are not what do you call it? That are not aggressive. Okay. Because when we say brain cancer, when you say cancer is something that is aggressive. Okay, infiltrating, damaging, attacking, and stuff like that. Okay, so you can have other tumors, and the common ones are, like I said, the meningiomas, the schwannomas, and the pituitary adenomas, which Uncle George actually had. He had the pituitary adenoma or pituitary tumor.
Okay, thank you for that. And I've got a couple more questions before I hand it over. Someone has asked in the chat, what is the relationship of HIV/AIDS and other viral infections in increasing the risk of brain cancers like gliomas and lymphomas? Is there an associated risk?
With the gliomas and most of the brain tumors, no. With the lymphomas, possibly, but it's not like there's a significant number of people with HIV are having lymphomas and stuff. They might have what we call the leukoencephalopathies, which might have some similar resemblance to the lymphomas, but with most of the brain tumors, no direct link.
No direct link. Okay, that's really okay.
The HIV and AIDS can actually be exposed to other kind of tumors, but not brain cancers, not brain tumors generally.
Okay, I'm looking through to see if there's any more questions in the chat. Someone has asked, which is quite interesting, I thought. Is it true that there are only 3 PET scans in Nigeria? And if yes, how come there's only so little? Is that a myth?
So let me say this very clearly, everybody. The fact that you even have 1 PET scan in Nigeria is by the grace of God. The fact that you even have one at all. And there's a place in Lagos that had the first one, and probably the only functioning one that we know about now. Okay, it's a facility in Lagos, and for a very long time we did not have any. And there's the African Medical Center of Excellence, which they just put forward in Abuja here, and I think they actually have one as well. So roughly about 2 in Nigeria, and 1 in Lagos and 1 in Abuja.
Okay.
And this the average person cannot even access this. The average person cannot access this.
And like, even if though we have 2, do we have the right kind of people to actually like work it or like be able to use it?
Yeah, I'm sure we do. I'm sure they do. But you're right, Amaka. When it comes to the issue of competence, capabilities, and stuff like that, we struggle in this part of the world. Really, really struggle. Our struggles are many. So again, for the Afro-Caribbeans who are in the UK, you are in some sort of paradise. Please use it. Okay? Extremely important.
Okay, well, I'm going to wrap up the questions now. And again, thank you so much, Dr. Okor. This has been such a thoughtful, interesting, informative, and educational session. There's even more questions coming through in the chat that we won't be able to get through, so we'll have to bring you back on for another session. Everyone, thank you so much for tuning in. The slides will be shared, and if you want to recap this, it will be on YouTube so that you can share widely with your friends, your family, because it isn't just us that are benefiting from this. We should share it so that everyone else can see. Dr. Okor, thank you so much for the work that you're doing in the UK and in Nigeria especially, and the education that you're sharing specifically on brain cancers and just everything brain health related. So thank you so much for that.
Yeah, so Amaka, the Caribbean and African patients are worth it, and the Nigerian patients are worth it.
Yeah, no, yeah, the Nigerian and Caribbean patients are worth it. We should try our hardest, like wherever we're from, just to we all deserve the same kind of healthcare that they have in the Western world, and we will get there eventually. So thank you so much for that, Dr. Okor. I want to shout out it's Windrush Day today, so we're going to be having some great events throughout the UK. We've got Tower Hamlets in London, and we've got Manchester Alexandra Park starting now, actually until 6 evening time. We're going to have a lot of events, speakers, music, games, food, just to celebrate Windrush and all things all things Windrush related. So if you're in Manchester or London and you're looking for something to do, go out. It's a beautiful day, and go enjoy and have fun with the community. I'm going to hand over back to Natasha now to round it up. So thank you again, Dr. Okor, and I'll see you all next time. Peace out.
I just extending what Amaka just said. Thank you so much, Dr. Okor. You put it in very accessible way, a topic that is so big and for some people so far away like me. And I was left enriched by this conversation. Further to that, the number of questions in the chat, not from patients and from medical professionals, really shows the importance of what you were sharing and the need to have these conversations. Amaka, so calm, collected, and insightful, guiding us through this. So thank you so much for making this time. Just wanted to remind everyone that Health Hour doctors are volunteers, and they are here just out of their good willingness and wanting to empower our community, Caribbean and African community. So couldn't be any more grateful to people such as Amaka and Dr. Okor for sharing their time. As you can see, Dr. Okor is in hospital right now, so time that they don't have plenty of. So I'm just going to share a little bit about what Khan is doing at the moment. Hopefully you can see my screen and it's nice and big. We have another fantastic session next week. I'm not even working, but I will log in because it's about celebrating melanin, and it's also about skin bleaching that is becoming ever so more, is a rising, I would say, issue from a personal perspective within the Caribbean and African community, unfortunately. Therefore, we're having a session with Dr. Shiadu. His sessions tend to be packed with people and questions. So we're really looking forward to welcoming him next Saturday with us. And don't miss out, share with colleagues, with friends. It will be a very insightful session. As Amaka shared with us, we have 2 celebrations today going, and you can see me in bright yellow with Khan written there. It's because I'm going from here straight to Alexandra Park to join my colleagues. And hi, if you're seeing us from there, I know we are being played on the big screen. And we have a celebration that is completely free. There'll be stall holders, there'll be food, there'll be music, there'll be, face painting, bouncy castle. Khan does not save when it comes to celebrating our people. And it's a lot of sacrifices that come into making this event. It's just purely out of, we want to make sure that our history, our culture is celebrated, because that is also health. And with that said, we are in London, Tower Hamlets, as well, having an event for the first time during Windrush in London. We're really happy. We're having a health fair. It's supported by the Tower Hamlets Council. And yes, health checks, wellness talks, entertainment, again, food, there'll be raffle prizes, all sorts going on in Tower Hamlets. So join us in the town hall. And we are very keen about highlighting and elevating people that are doing the absolute best for our health heroes. And we also have the mission of highlighting Black healthcare professionals, people that are working sometimes with little resources or little recognition, people working across the world, obviously with a connection with the UK. But what we really want is just to celebrate them. There's been hundreds of nominations, I can tell you. And we have just finished a shortlisted, we finished to shortlist people. You can see on social media, people really happy to be shortlisted. So you don't want to miss the celebration, I'm telling you. And it's going to happen in a Park Plaza in Westminster Bridge in the 12th of July. There's only a few individual tickets available, so do join us. And if you work with big organizations and you want to get a full table for your team, celebrate, Black excellence, and you just enjoy the culture and see these wonderful people go on stage, please do get your ticket as soon as possible. Time is running out. With that said, in October, we are already preparing because, Cannes does not miss a beat. We are joining in Greater Manchester to celebrate Black History Month in the Great Manchester Cathedral on the 25th of September. Entry is free. As you can see, renowned people are there, the community, the young people, our mayor will be there as well. So it's not a small thing. It really isn't, and is fully supported by the Greater Manchester Combined Authority, and they are already with us planning and actively making sure that Black History Month is celebrated in Manchester. And last but not least, very, very important, we have our still ongoing call for evidence on reproductive equity and fibroids crisis. We already had more than 500 entries. We are looking to hear directly lived experience from Black women with fibroids and reproductive health-related issues. We need the research, we need the data, we need to be empowered by your lived experience, by your care needs, by what you have gone through. We need that information so we can put these policies forward in government, because Cannes is not just about the services and the events are very important, and health literacy, but we're also trying to move policy. We are trying to push things forward for our people in systematic ways. So do join us if you have the chance. Just scan the QR code and share with us. Links are also in the chat. I've said enough, and thank you so much for being with us today. Amazing session. I shall see you next week.